Hi. When a patient presents to you with a brachial plexus injury, it may be obvious that he has the injury, but what may not be obvious is the severity and extent of the lesion.
The aim of such an evaluation would be to localize the lesion, whether it is preganglionic or postganglionic, and to determine the severity, that is, whether it is a neuropraxia or a neurotmesis. We also need to evaluate the level of the injury, the roots, trunks, divisions, cords, or the terminal nerves. We have four modalities with which to achieve this assessment: history, physical examination, imaging studies, and electrodiagnostic studies.
In this presentation, we are going to see the physical examination alone.
We need to assess the brachial plexus injury either in the acute, subacute, or quiescent stage. In the acute stage, the brachial plexus injury is not a priority, other injuries are. In the subacute stage, it may not be possible to do a complete examination. After the edema and pain has subsided, it is the best time to make a complete examination. As he walks in, notice the gait, get him to sit comfortably on a stool, and then begin the examination. When you examine the neck, look for any evidence of bruising. Look for scars on the neck, which could be due to either a previous surgery or due to the injury per se. In some patients, the neck will be tilted to the opposite side. This is due to the paralysis of the muscles on the affected side, and so the muscles on the unaffected side tilt the head towards the normal side, as you can see in this patient. This indicates typically a preganglionic lesion. Then we need to examine in the suprascapular area for any fullness. This will indicate a postganglionic lesion. The next point to be noted is the loss of contour of the shoulder, which is due to the paralysis of the deltoid muscle and wasting of the muscle. This is the normal contour, and on this side you can see the abnormal contour. Examination of the face will reveal the Horner syndrome. This is typically with meiosis, ptosis, anhidrosis, and enophthalmos. There can be different types of pain on palpation in the supraclavicular area, which could be pain radiating to the upper limb also. This is typically a neuroma pain suggesting a postganglionic lesion. On testing the muscles, there are four things to be done. One is performing the movement, testing the power, palpating the muscle that is being moved, and lastly, if there is no movement, look for the passive range of movement. The muscle power can be assessed either by the MRC, the modified MRC, or the Louisiana State University muscle grading. The simplest way of measuring the power of the muscle would be while palpating for the muscle contraction. If there is no palpable muscle contraction, it is M0. If there is palpable muscle contraction detectable by the examiner, it is M1. If there is active joint movement present with gravity eliminated, it's M2. If there is full joint movement possible against gravity, it is M3. And full range of movement against some resistance, it is M4. And full range of movement against maximum resistance is M5. The LSU-MC grading combines both the muscle, that is the motor, and the sensory grading. While examining the muscles, it must be done in such a way that no muscle is missed. This can be achieved by the walking the plexus technique, consisting of 13 steps, starting with sensory examination. This diagram shows the sensory dermatomes. But it's easier to remember the lateral aspect of the arm or the regiment badge area is the C5 area. The lateral aspect of the forearm is the C6 area. The lateral aspect of the thumb up to the tip is the C6 area. The index, mid and ring fingers form the C7 area, and the ulnar border of the palm forms the C8 area. The medial border of the forearm forms the T1 dermatome. The medial aspect of the arm is supplied by the intercostobrachial nerve, which is T2 territory, T2 and 3 territory. To remember easily, that is the C5 area, that is the lateral aspect of the arm, the medial lateral aspect of the forearm, which is the C6 territory, extending up to the tip of the thumb, the C7 territory, extending up to the ring finger, the ring and little fingers up to the palm and the ulnar border C8 territory, and the medial aspect of the forearm, which is the T1 territory. Clinical examination of the phrenic nerve would be by percussing in the intercostal spaces during inspiration and expiration, but radiological evidence is more confirmatory. The third step of examining the dorsal scapular nerve involves testing the rhomboids and the levator scapulae. When there is a paralysis of the rhomboids and levator scapulae, there is a difference in the position of the scapula. You will note here that the affected side, that is the left side, the scapula has moved laterally and the inferior angle is also rotated laterally. The rhomboids are palpated medial to the medial border of the scapula, more towards the inferior angle where the trapezius will not be overlying it. The classically described test for the rhomboids involves placing the patient's palm facing outwards on his lower back and asking the patient to push backwards against resistance. If the patient is unable to move against resistance, he needs to be examined in the prone position. The patient is asked to lie down with his arms by the side and palm facing upward. He is then asked to move the shoulder backwards and the examiner feels the medial border of the scapula for movement. If movement is felt, it indicates M3, that is, movement against gravity. The next step involves testing the serratus anterior innervated by the long thoracic nerve. On testing the serratus anterior, the first thing is to note the position of the scapula. You will note that on the right side of this patient, the involved side, it has moved medially, that is towards the midline, and more cephalad. The classical test for examining the serratus anterior is to ask the patient to push against a wall. This may not be possible in brachial plexus injury patients who have a total paralysis of the upper limb. The test can be performed in sitting position with both arms outstretched on a table in front. The examiner uses his thumb and fingers to track the movement of the scapula and feel the serratus, and the patient is asked to project his entire extremity forward while the examiner feels for the movement of the scapula away from the midline. If the patient is unable to move against resistance, he needs to be examined in the supine position, and the examiner supports the upper limb with one hand and feels the scapula with his other hand, and the patient is asked to move his limb forward. If he is able to do so, it indicates M3, that is movement against gravity. Examining the suprascapular nerve involves testing two muscles, the supraspinatus and the infraspinatus. For testing the supraspinatus muscle, ask the patient to abduct the arm against resistance. At the same time, try to palpate the muscle by asking the patient to turn to the opposite side so that to relax the trapezius muscle. If the patient is not able to abduct the shoulder in the test as shown, gravity should be eliminated and the supraspinatus should now be checked. The infraspinatus is tested with the patient in supine position and he is asked to externally rotate the shoulder. Examination of the axillary nerve involves testing the deltoid and the teres minor. The anterior fibers are tested by asking the patient to abduct the shoulder from a forward position of the shoulder. The middle portion of the deltoid is examined in the similar manner except that there is no forward flexion and only abduction is done. The posterior portion of the deltoid is examined in the same position as the middle portion, but instead of abduction, the patient is asked to slide his arm backwards. At the same time, the posterior deltoid fibers are palpated. Both the external rotators of the shoulder, the infraspinatus and teres minor, are to be tested. The teres minor is tested by laterally rotating the humerus with the flexed elbow. The next step is testing the thoracodorsal nerve via the action of the latissimus dorsi. For testing the latissimus dorsi muscle, the patient can be asked to forcefully adduct his arm against resistance and the latissimus dorsi muscle can be palpated. A better test would be to test the cough reflex by placing the hands, examiner's hands, on both sides of the flank and asking the patient to cough. The reflex can be felt when the latissimus dorsi is active. When the patient is not able to do the test as demonstrated, gravity can be eliminated and the patient is made to lie on his unaffected side and the muscle is tested again. Now two branches from the posterior cord, that is the upper and lower subscapular nerves, are tested. The upper subscapular nerve supplies the subscapularis and the lower one supplies the teres major. The subscapularis is examined with the patient in sitting position, shoulder abducted to 90 degrees and supported by the examiner's hand. The patient is now asked to move the arm backwards and upwards. If he is able to move it, it indicates M3 grade. It is a little more difficult to test the teres major in isolation and its function is best felt by palpating the muscle lateral to the lower border of the scapula when testing the subscapularis and latissimus dorsi. The medial and lateral pectoral nerves together supply the pectoralis major muscle. But we must remember that the lateral pectoral nerve supplies the clavicular head and the medial pectoral nerve supplies the sternal head. To test the clavicular fibers, the patient is in a sitting position with the shoulder abducted 90 degree, elbow partially flexed and the palm facing downward. While the examiner keeps palpating the upper fibers of the pectoralis major, the patient is asked to move his entire upper limb forward. To test the sternal fibers of the pectoralis major, the patient is asked to move his unsupported arm towards his opposite hip and the sternal fibers are seen or palpated. The motor supply by the musculocutaneous nerve is mainly tested by testing the biceps and the brachialis function. Biceps function, there are two main functions. One is elbow flexion, the second is forearm supination. The elbow flexion is tested and the power of the biceps is noted. The second point is the supination, where the patient is asked to supinate the forearm with the elbow kept in 90 degree flexion. This is to make sure that it is the biceps that does the supination and not the supinator. Testing the brachialis is also simple. Elbow flexion is tested with the forearm kept in total pronated position and the patient is asked to flex the elbow. It is the brachialis that works here. The radial nerve is next evaluated by examining the following muscles: the supinator, the triceps, brachioradialis, extensors of the wrist, fingers and the thumb. When testing the supinator, we must remember that the biceps must be kept elongated, that is, the elbow must be kept extended. The patient is asked to forcefully supinate the forearm against resistance. Now it is being done on the affected side. You will note that there is no movement of supination. Patient is not able to supinate. This is a case of C5-6 lesion. When testing the triceps, it is important to test the elbow extension against gravity because gravity is going to aid in the extension of the elbow. In testing the brachioradialis, an important point again, elbow flexion must be tested with the forearm in mid-prone position. Now it is being demonstrated on the normal side and the patient is asked to perform the flexion. You can palpate and even see the brachioradialis muscle getting prominent. On the affected side, when the patient is asked to flex the forearm against resistance, you can make out that there is a depression in the area where the brachioradialis should be. Patient is not able to flex the elbow, but there is a muscle that is getting prominent. That is the extensor carpi radialis longus. This is also a case of C5-6 lesion. The radial nerve involvement in the hand along with the median nerve and the ulnar nerve can be tested as follows. We check the complete fist, wrist extension, finger extension and wrist flexion. In testing the hand muscles, first we palpate the thenar muscles, the tone of the thenar and hypothenar muscles, and then check for the opposition. Opposition must be opposition of or pulp to pulp pinch between the thumb and the fingers. Next is checking the lumbrical position, the integrity of the interossei and the lumbricals. Then the abductors, that is the dorsal interossei supplied by the ulnar nerve. This finger abduction test is actually specific for T1 root. The flexor digitorum profundus of all the fingers are individually tested and the tone of the joint is also tested after making the flexor digitorum profundus contract. Once it is done, the FDS of the index finger is then checked by asking the patient to oppose the index and the thumb, and if the patient is able to make a good O. Next is checking the flexor digitorum superficialis of the middle finger, the ring finger and the little finger. Along with this, the tone of the DIP joint must be checked to make sure that it is not the FDP that is performing the action. There are two simple tests to demonstrate the intactness of the ulnar nerve and the median nerve. The first is asking the patient to cross his index and mid fingers, which indicates an intact ulnar nerve. And a good opposition with a good tone in the thenar muscles indicates that the median nerve is intact. We also need to assess the regrowth of the nerve either spontaneously or after a procedure. This is important to plan the continued management. There are three phases in the growth of the nerve to return of function. The first phase is the growth of the nerve to reach the destination. This phase can be assessed clinically by the Hoffman tunnel sign. The second phase is when the axons reach the muscle but action of the muscle has not yet started. This stage can be assessed by the tender muscle sign, that is, tenderness on palpating the muscle that is just innervated. This innervated muscle slowly gains in strength, and this can be assessed by the MRC grading or the increasing weights that can be lifted by the individual muscles. As far as the tunnel sign is concerned, it should be elicited by percussing along the course of the nerve from distal to proximal. The patient will complain of pins and needles in the area of distribution, and it may be static or progressive. The following do not come under tunnel sign, that is pain in the neck area which indicates injury to the cervical plexus, and pain radiating to the upper limb on tapping in the neck indicates neuroma pain, which means that there is a total severance of a nerve and does not indicate regrowth of nerve. So clinical findings that suggest preganglionic lesion are the position of the neck, the presence of Horner syndrome, the presence of emptiness in the supraclavicular area and burning pain in the anesthetic limb, dry skin over the area of anesthesia which can be tested by moving a plastic pen over the area, paralysis of serratus anterior rhomboids, and absence of tunnels or neuroma pain.
It is not enough just to do a complete physical examination of a brachial plexus injury. It is also important to document it correctly and analyze the results of the examination.
The motor involvement can be recorded in the Merle-Dobbin chart, which shows not only the involvement of the muscles but also the power of the muscles, which is color coded. It also shows the root level, which gives you an idea of about which of the roots that are involved. This is an example showing a C5-6 lesion in a patient and the involved muscles being recorded. The sensory involvement and the presence of pain is also recorded on a chart. If the C5-6 is involved, the supraspinatus and infraspinatus muscles are paralyzed through the suprascapular nerve. The involvement of the flexor carpi radialis, pronator teres and sensation on the lateral half of the hand through the median nerve. The involvement of the biceps, the brachialis and sensation on the lateral aspect of the forearm through the musculocutaneous nerve. The involvement of the deltoid muscle and sensation on the lateral aspect of the arm through the axillary nerve, and the involvement of the brachioradialis and supinator with sensation on the lateral aspect of the dorsum of the hand being affected through the radial nerve. These are the findings when the C5-6 are involved at the truncal level. When the C5-6 roots are involved, that is, there is a rupture of the roots, you will have all the above findings: paralysis of the rhomboids, levators and serratus anterior. If the roots have been avulsed, there is also a paralysis of the paraspinal muscles due to the involvement of the dorsal primary rami. If C7 is involved at the truncal level, there is a loss of sensation on the middle finger roll through the fibers contributed from C7 through the median nerve, involvement of the triceps muscle, but that is also neurotized with C8T1 and this is through the radial nerve. Then the involvement of the latissimus dorsi, which is also supplied by C6-8 lesions through the thoracodorsal nerve, and lastly the teres major through the subscapular nerve. If the C8 and T1 is involved at the truncal level, the flexor carpi ulnaris, abductor digiti minimi, first dorsal interosseous, deep head of the FPB, and sensation of the ulnar two fingers and sensation on the ulnar half of the dorsum of the hand is involved through the ulnar nerve. Likewise, through the median nerve, the FDS of the fingers, the FPL, the FDP of the index mid, the abductor pollicis brevis, flexor pollicis brevis and the opponens pollicis, along with loss of sensation on the lateral aspect of the hand. There is also a minimal loss on the extensors of the fingers due to the involvement through the fibers to the radial nerve and loss of sensation on the medial aspect of the forearm. If CA-T1 has been involved with involvement at the roots level and avulsion has occurred, all the above are present along with Horner syndrome. Clinical findings that suggest preganglionic lesion: we have already seen the abnormal position of the neck, Horner syndrome, emptiness in the supraclavicular area, no tinals or neuroma pain, but burning pain in the anesthetic limb, and paralysis of serratus anterior, rhomboids, and the paraspinal muscles. Similarly, clinical findings suggesting postganglionic lesion, swelling in the supraclavicular area, tinal sign or a neuroma pain associated with fracture clavicle, and intact action of serratus anterior and rhomboid muscles.
A clinical examination will give a fair enough diagnosis. It has to be followed up with prudent investigations for the complete evaluation of the brachial plexus injury. Thank you.